Great. So we're hoping to have a more conversational style with this session, exploring the challenges of data protection and ethics with the project for C3-Cloud. But we felt that we would start with a brief introduction of us, which Theo has kindly done, and as well as a brief talk from me about data protection and ethics, especially in light of the last 5 months. In addition to my roles with IHD and UCL, I'm also actually an information governance lead for the UCLH NHS Foundation Trust Biomedical Research Centre in the Clinical and Research Informatics Unit. So we've had obviously a lot happening in the last 5 months, and I think some of the experiences that I've been exposed to really put a different perspective and shine a new light on the importance of the work of C3-Cloud and other initiatives in this area. So there'll be a brief reflection and a consideration of what we keep hearing is called the new normal in light of COVID-19, but also to explore a possible new mandate for ICT-driven healthcare, not only to enhance patient experience and care outcomes, but also to make sure that we are better prepared for dealing with pandemics like COVID and global health more generally. But then we'll get to the conversational part. I shouldn't be talking for more than about 5 minutes, but then we're going to have the conversational elements where Gunnar and I will discuss what's happened. I'll ask Gunnar some questions. I think he's going to ask me some challenging questions as well, which we hope will be informative. So moving through, when thinking about ethics and data protection, one thing I've learned in the last 4 years, ever since GDPR was actually agreed, was that GDPR is a very good way of framing the conversation. It's a foundation in terms of protecting data, but also in the kinds of things you have to think about when protecting that data. So in the context of healthcare, health innovation and research, we've got to remember that the data that is gathered within a confidential therapeutic relationship in the first instance, but with patients being empowered to care for themselves in partnership with their practitioners and using new tools and technologies. We have to remember that this data is precious, it is sensitive, and that it has to be handled lawfully, certainly, and that's something GDPR mandates. And when we say lawful, broadly speaking, what we mean is that the use is ethical. It's had some kind of ethical oversight, independent or otherwise. Different member states across the EU and more widely across Europe and the world all have their own laws around ethics, which you must abide by to comply with GDPR. And in broad terms, that means that the use of data will not cause harm and will actually be equitable for the data subjects and for the partners in terms of handling that data to provide them care. But it also has to be safe. So the data that we're using and the tools that we're developing have to be providing us with information that is useful in the context of care, but also safe and informing decisions rather than hindering them. But we need to have data that's sufficient for those purposes. So you need to use enough of the data to make sure that you're actually doing what you need to do and you're not making any mistakes. But it's also accurate. That has to be something to be considered. So data quality is paramount, and this is mandated by the GDPR principles. But it's also got to be secure, and there's any number of standards and laws around what secure means. GDPR doesn't make specific prescription for that, but we do know that there are laws and there are standards that we must adhere to, and there's an explosion in cybersecurity concerns, and have been for some years, around the use of highly sophisticated technology that may be vulnerable to attack. But we only use the data that we need to use, and that's a bit of a challenge to actually define. But you should only use as much data as you need to achieve your goals. If you need more, you have to make a case for it. If you don't need as much, then you know better for next time. But you don't always know that clearly, and that's where things can be a little bit confusing. But you also have to be accountable for what you're doing. So that means you've got your policies in place, your contracts in place, but also proof that you're actually abiding by GDPR and good practice beyond a declaration to that effect. So you've got to be prepared to account for what you're doing. But I've left what I think is the most important one to the last, and that's being open, clear, and honest about what is happening with data, with patients' data, certainly in this case. So that means you have to be transparent about the processes, about your intentions, about how you're handling the data, and who else has access to it. And for me, this is really the fundamental element where you begin to make data subjects, patients, and the public more partners in our endeavors together by having an open discourse about what this entails. And you don't always know how it's going to pan out. You can't make guarantees about security, you can't make guarantees about learning, but we are on a shared journey with patients and the public, especially when we look to things like C3-Cloud, where we're looking to integrate the flow of information and the power of care much more with day-to-day life. And that's so important to get right. But moving on, we couldn't have a discussion around this area without reflecting on what's happened in the last 5 or 6 months. So obviously the COVID-19 pandemic has shaken all of us to the core and has redefined our working practice and the demands on what we need to do in order to manage it, not just as private individuals or citizens, but also when we do occupy health roles, governance roles, and empowerment roles in terms of ICT and information. What I want to do is just take England as a case in point very briefly to set the scene, partly because it emphasizes the fact that whereas GDPR applies across all member states and other countries outside the EU are also taking on board some of its provisions, we've got to remember that member states have their own legislature, they're independent sovereign nations, part of the European Union, and they have made law to that effect. And in the case of the UK, we have 4 jurisdictions that vary wildly. One is England, of course, the other is Scotland, we have Wales, and we have Northern Ireland. And this is a key point where when COVID-19 came to practice, in England, in our statute, we have something called the Control of Patient Information Regulations. And in broad terms, that means that the duty of confidence is set aside, which for specific purposes, like within COVID-19, there are defined purposes, including research into dealing with the pandemic, the need for consent has been set aside for accessing medical records. Now, this is a vital point because when in reality, that regulation applies only in England. It doesn't apply in Scotland, it doesn't apply in Northern Ireland, and it sort of applies in Wales. So we've had to work around different regulatory mechanisms for the approvals and so forth. But even that aside, the COPI regulation sets aside the fundamental basis of trust between doctor and patient, the duty of confidence. It does not set aside data protection law. So in working with the new normal, we have still had to abide by those principles of data protection, which I think has been essential, quite frankly, because it's given us a common framework on how to protect data. It makes sure that we are providing data that's accurate and sufficient, and it has made us be transparent with the patient community. So all the public and patient involvement we've been doing has ramped up from the old normal where we would have a few meetings on occasion. We've tried to involve patients as much as we can in decision making and being transparent. So data protection and indeed research governance have not been set aside. Ethics approvals still must go ahead through expedited review, but this is something that we need to bear in mind moving forward because we've actually been able to move very quickly. But the other elements as well that have made people nervous about data flows, particularly international data flows, are the other elements that have cropped up, including the overturning of Privacy Shield by the European courts. So data sharing with America now has to be under a new treaty or under standard contractual clauses, and as well as the ongoing saga of Brexit, where the UK is seeking adequacy from the European Union. We don't know whether we'll get it or not, but this is a watching brief. These 2 elements, especially Brexit, brought about a great deal of uncertainty, and we've had to adapt much more quickly in terms of making sure that data will still flow. But there is uncertainty, there will continue to be uncertainty, and I think we have to bear this in mind moving forward. But without taking up too much time, because I want to get on to the conversational elements, I'm going to end on this slide. I would argue we've got a new mandate now with ethics and data protection. We've seen how quickly we must move with COVID-19, and we've seen how uncertainty is pervading all of our work, and that can make us more nervous and more conservative in our approach for data sharing. So this is one thing that struck me, to try and summarize this in 4 points in terms of the new mandate. First off, no prevarication. What I mean by prevarication is it's not a widely used word, but it's something that data protection and IG officials are sometimes accused of doing. It means fussing and faffing and wasting time without actually getting the work done. We need we need pragmatism, but no prevarication. So we do need to be able to come to decisions quickly and be able to justify them and work with others to make sure they work. We mustn't use data protection regulation and excuses to cause disruption to reasonable data flows. We have to now actually champion the flow of data to support things like C3-Cloud and managing pandemics. We must have clear answers to questions, and we have to do those quickly and turn them around quickly. And no is not an answer anymore. The outright blanket refusal of sharing data would breach GDPR articles, but at the same time, we have to now reflect and look to where we can move outside of our comfort zones, but defend our decisions. So this is what COVID-19 has taught us in regulatory terms, I would argue. But these are also mandates that we need to follow if C3-Cloud and other initiatives like this that are so important in terms of providing care are going to succeed. So on that note, I'm going to bring up my questions, and I will stop sharing the slide so that you can see Gunnar's and my faces during the discussion. Has the screen stopped sharing, by the way? I just want to make sure that you're not.
Yes.
Excellent.
Can we? Do you hear me also now, Nathan?
Perfectly, Gunnar.
Fine, good.
So, shall I start off with my first question?
Or can I, before we come to C3-Cloud specifically, can I just make a brief comment on your statements on how COVID-19 has changed everything? I like to disagree a bit. First of all, of course, in C3-Cloud, we haven't really been dealing so much with the COVID-19 problem, but I think that, of course, in various jurisdictions, we had to deal with issues of a pandemic and things like that. But I think also that legislation in some way has been prepared for that. Of course, we have different national legislations on how to deal with severe public health issues like a pandemic, and we don't need to discuss variations and Brexit case and such things. But I mean, we always had the ethical challenge between providing as much care as possible for patients and trying to comply with all sorts of regulations from the European Union or national things. Because I also claim that we've had in most European countries, I mean, already various legislations that are not too different from GDPR. It's not that much that is extremely different, that we need to protect sensitive patient information, of course.
Absolutely. I think in that sense, to explore that a little further, my sense of it is that you're absolutely right. We've had regulatory components within English law and legislature that do match the GDPR principles that predate them by about 20 years, as it turns out. But I think with GDPR, what's happened was that it set everyone a little more nervous and they were more concerned about compliance. But I think my point about COVID-19 is that it's a reminder for us not only to deal with the pandemic, but also in terms of dealing with care, that we can't get bogged down in worrying about compliance when, in fact, we've actually been doing much of the compliance for years anyway. This isn't really necessarily new things. I think it's an important point.
The European Commission had requirements on R&D projects even before GDPR was enacted, and we prepared the project before GDPR actually was live. And I don't think that the fact that we eventually got GDPR has changed so much for us. And I'm very pleased and like to thank my co-workers that data protection and privacy was always a strong concern in the group that planned for C3-Cloud. So it wasn't something we added in the end when we realized that the Commission or various legislators would require it, but it was prepared for already when we were drafting the application, really, that we need strong technical protection for confidentiality, for instance, which is what most people think of, but I mean less discussed and equally important actually for healthcare is availability and integrity to make sure that the data is, as you said, also correct and useful. And it's not just to protect confidentiality, then you can have a black screen for everything. That's not the solution. Luckily, I think we have had no problem really with availability with the C3-Cloud solution.
Absolutely. It seems that way, and I think you're absolutely right. You don't want to be regulating to the point you're doing harm, because that's missing the point, and in and of itself is dubious in ethical terms, for sure. Gunnar, on that note, so on reflection, you've given a bit of an indication of you know, how you try to be pragmatic with C3-Cloud, and without putting you too much on the spot, overall, I'd like you to think about and share with us how you think C3-Cloud and the ethics committee have actually fared over the last few years. How do you think you've done in terms of not only meeting the regulatory requirements, but enabling the project?
Yeah. First of all, I like to remind us that C3-Cloud is a research project, and we need to collect data for evaluation and include patients and other stakeholders like the health professionals for purely for research purposes. But on the other hand, so we needed to deal with that, and we needed to apply for ethics permission in the various countries, and that was an interesting exercise, because these rules are not common European ones in the same way. What do you need to start a research project of this nature in the different countries? So although we had a common research protocol and we agreed on what we needed to specify, there were comments from the national authorities which we had to deal with, but overall that process worked rather smoothly, I say, and we got the permissions we needed to deal with the research aspect. But of course we also were all the time hoping that this would be a solution that would stay on, and we will discuss that in the further sessions here, and that the major challenges was not based on the fact that it's a research project, but for this type of solution to help patients and their health professionals, what is required from an ethical point of view. And of course we need strong technical protection, and I think Gotche also wonderfully described how that is done, and I'm not going to get into that, just to say that I was pleased, and the ethics committee, that the technical managers already had accounted for using the good encryption-based methods and using standard protocol as much as possible, so we could integrate with the various solutions in different countries, for instance on providing identities and some of the authentication solutions used nationally, for instance for health professionals, which is an issue if you're trying to do something on a pan-European scale, definitely. So that was fine. We actually had one ethical issue which I can bring up, which was a potential data breach early on in the testing phase due to a human error. A technical partner got access to live patient data which they shouldn't have, and that was discovered in a couple of days and stopped, and to our knowledge no data was actually misused in any way, but it was also a test, and we reported this according to GDPR on as a potential breach, etc., and everybody was pleased with the way we handling it. But it was actually before we had started to use the system live, which has only been for the last year or less than that actually.
Absolutely. So it's good to have had that learning. I was wondering as well, Gunnar, has there been any other learning that you've had that will help make these kinds of initiatives live longer and be more sustainable into the future?
one of the things we decided early on was to, contrary to the title of the project, not to use the cloud. I mean, initially there was an idea to have a common European cloud for all these services, but we decided it would be too risky at this stage, so it was deployed within the safe environments of these 3 healthcare regions, and the servers used for C3-Cloud were sort of under the same general protection as the electronic health record systems already used. And remember that these regions are rather mature. The professionals and patients were used to the fact that their clinical records was managed electronically, and by and large the C3-Cloud data has been managed in the same way. But if you want to use real cloud services hosted perhaps in countries also outside our safe harbor, then we have an issue, and that's something which needs discussion in the future. Theo,
Absolutely.
you want to interrupt us now because of time?
So I'm afraid we have reached the time, but maybe if Nathan and Gunnar, you would like to give a final comment in the next minute.
Of course, Gunnar, would you like to go
say
first?
one word? That one aspect of GDPR which we haven't really followed is the portability principle, that we want patients to be able to take their data to a new health provider. Of course, the major issue is to take their electronic health record. Perhaps the international patient summary can solve some of that problem. Eventually, of course, you would like to have an advanced care plan system also being portable, but there is today really no technical capability for anybody to receive the C3-Cloud data. So we are happy that we can't really solve that issue yet, but it's a challenge for the future.
Absolutely. And I think what I would like to finish on saying is that as much as my past has been around engineering healthcare interventions and record systems, my present and my future is very much within the regulatory environment. And the first rule of thumb is that we don't do harm by over-regulating or over-interpreting regulation. It's so important to be open and frank about the challenges and the errors and the breaches, but we have to build things that are secure and robust. Otherwise, we'll be doing more harm than being overprotective. So thank you, everyone.
Thank you both, Nathan and Gunnar. I think this indeed is an interesting area, and I totally agree with you, Nathan. And based on the comments of Gunnar, we need to be honest and transparent about GDPR. And the way we have handled it, as Gunnar described in C3-Cloud, has been that approach. So fantastic! Thank you both for the session.